So, Dr. Jassir, so thank you very much for being here today and being able to present this case to us. Um, to everyone who joined the meeting, welcome. We are going to have a pretty nice discussion with Dr. Jassir and the supervising faculty of the Florida Atlantic University. So, Dr. Jassir, thank you very much once again, and you may start whenever you want. We will have some panelists joining as well, so they are going to comment on your case. If you do have any specific points during the presentation where you already have this planned in a way that we can start a discussion, just let me know. If you want me to help to moderate this session in any other way, just let me know as well. But feel free to start whenever you're ready, and we will have the panelists joining in as well.
Absolutely, and I want to thank you for having me today. Just for a brief introduction, my name is Fauzi. I was born and raised in Colombia, and I'm a PGY3 here in Florida Atlantic University. We do trauma in St. Mary's Medical Center, and that's where we saw this case. Again, thank you for giving me the privilege to present. I will give some space for the panelists and the people in the audience to chime in, and I would love your help with moderating too. That would be great. All right, so let's get started. First of all, this is a privileged document, and the patient information in the chart is to be kept confidential. So let's start here. We got a trauma alert as level 1 trauma for a 64-year-old male with unknown past medical history at the time that was brought into the trauma bay after being struck by a vehicle at high velocity while he was on his wheelchair. We later on, throughout his hospital stay, found out that he was in a wheelchair due to a diabetic retinopathy, was legally blind, and he had some mild dementia, which impeded his ambulation. He did not have any loss of consciousness, and he did have a massive degloving genital and perineal injury involving the penis and the scrotum. Regarding the primary survey, his blood pressure upon arrival to the trauma bay was normal, 120/60. His heart rate was in the 70s. He was saturating 93 on room air, and his respiratory rate was 12. He was protecting his airway. His breathing was non-labored. He was speaking full sentences at the time. He had bilateral breath sounds, symmetrical chest rise, and regarding circulation, he had palpable +1 femoral pulses and radial pulses on all of his extremities. Again, his systolics were in the 120s. 2 large bore IVs were placed. There was no blood at the urethral meatus, and a Foley cannulation was attempted at this time, which was unsuccessful. His Glasgow was 15. He did have an unstable pelvis at the time. We immediately called for a binder, and he had some abdominal tenderness. We did get to do a rectal exam at that point in time, and there was no blood in the rectal vault, and there was no discontinuity of the sphincter. We did an EFAST immediately, and it was negative at that point in time. Here are the x-rays from the trauma bay. His chest x-ray was basically unremarkable. His pelvic x-ray showed an open book fracture with multiple iliac AL fractures, and we'll go into that a little bit further down the line in the presentation. And we immediately placed a binder, as I mentioned earlier. And then we were able to do right there at the trauma bay a retrograde cystourethrogram that, as you can see somewhere around here, had extravasation of contrast. And this is a picture, an image depicting the degloving injury of the basically mons pubis down to the perineum. So I'll pause here and give the opportunity for the distinct panel to weigh in on what you're thinking, what the next steps should be, and things to keep an eye out for.
Perfect. Thank you. Dr. Untrack, shall we start with you?
Certainly. So a really unfortunate man that at 64 has mild Alzheimer's disease and diabetic retinopathy, blind in a wheelchair, and then he's got this injury, but he's hemodynamically stable and Glasgow Coma scale of 15. You have the 2 large bore IVs in, and you can see the extravasation, which looks to be, is it intraperitoneal? To my eye, I think it is intraperitoneal. So, but he's stable. So I think you can, he'll need an external fixator for the pelvis because of he's got the large pelvic wound, and that would give you access to deal with the wound later on. And then you might also, since he's stable and you have a binder on, you can do a CT of the abdomen and pelvis. That would be my next step while he's stable.
Excellent. Dr. Kasim, do you want to give additional insights?
Good morning. So when you see a case like this, first thing you should do is you should pray. This is a horrible injury for an unfortunate man, who is riddled with multiple comorbidity. And then to get hit by a car and be in a predicament like this, it's really not very fair.
No.
I think Providence has dealt unfortunate hand to this man. And so be as it may, I think this is not going to be a walk in the park case, and you better know exactly what you're going to be doing in a case like this, because you will need a lot of help from various other subspecialty people who are probably much more versed in treating something like this than you alone as a trauma surgeon, even in a big hospital such as Portland, Oregon, or Vancouver General Hospital, or wherever you are practicing. So what would I do? First, you did the right thing. Everything is right there. And did he have intraperitoneal bleed? Is there any obvious blood accumulated in the pelvic cavity, which is intraperitoneal? Because if he has that, then sending him to the CT scan may not be the most appropriate thing to do. So first thing I would determine is, does he require surgery immediately to stop the bleed? And even though his blood pressure is adequately normal, he may be compensated at this time, and suddenly he's going to crash on you. I mean, looking at the pelvic X-ray there, you should be aware that such an injury has a predisposition to a lot of massive problem in the pelvis, where vessels will get torn up and he's going to bleed to death. So I think if you are in a center where they are very familiar using technique to stop the bleed in the pelvic cavity, having a appropriate introducer into one of the pelvic vessels or femoral vessel, so you can deploy balloons and catheters and things like that into the lower part of the abdominal aorta to get somewhat control while you are getting him appropriately resuscitated with blood product and getting ready to take him to the operating room, like Dr. Untrak said, that he will require fixators and orthopedic people working on him while you assess the abdominal cavity for other injuries. Of course, he has an obvious injury to the bladder, and I agree with Dr. Untrak. This looks like intraperitoneal, and it needs to be oversewn, drained, etc. And this is going to be a horrible case, and be aware that you are in the tiger country. Get as much help as possible from other people as well. I will stop there for the time being. Thank you.
Thank you, Dr. Kasim. I noticed that both of you, Dr. Kasim and also Dr. Untracht, talked about the cystogram. So, Dr. Untracht, can you give any tips for anyone who's looking at this image on how to identify if this is a intraperitoneal or a extraperitoneal extravasation? Is there any way we can look at it and like try to make sure that it's going inside the belly and not in the extraperitoneal space?
Yeah, the only thing looking at this, it seems to be accumulating in the cephalad portion, but I guess you really can't tell just on one view. If you had two views, then you can see anatomically exactly where it is, but you really can't tell. There's some hints. He had a negative EFAST, so that means that the sonographer didn't see fluid or outside the bladder. There was no bow tie sign, and there was no sign of fluid in the cul-de-sac. So that argues against intraperitoneal rupture. So at this point, it's not, if that were his only injury, it wouldn't be as urgent. So looking at that, I can't tell. It might very well be extraperitoneal, given the way the ultrasound looked. You wouldn't really necessarily see an extraperitoneal rupture. If you had separation of the urethra, the prostate might be way up in the field, so that would be a clue. But and that's why I say, and because there's no evidence of intraperitoneal blood or fluid with the stable vital signs, you have time to go to CT, and then you'll know exactly where the bleeding is. You'll be able to tell if he has arterial blushing, so that you can take him to interventional radiology. And Dr. Kasim's points were all very good. I mean, possibly one thing that I might do in the ER, especially after conferring with a colleague like Dr. Kasim, is put in a femoral A line, so that if things deteriorate, this would be an excellent indication for the Ebola at zone 3, which would buy you time, especially if you can document arterial bleeding on a CT scan. But I can't really say looking at that. I mean, and it's almost slightly academic at this point, whether it is risen, because there are other higher priority issues to deal with right at this point.
Definitely. And would you consider, I'm sorry, yeah.
One of the things that you could do would be a lateral and oblique film. A lateral film combined with the AP film that you have there, it'll give you somewhat of a suspicion whether you're dealing with the intraperitoneal rupture of the bladder or not.
And then ultimately, I did not put in the laterals, but we did take some in the trauma bay, and it ended up being disruption of the prostatic urethra without any intraperitoneal extravasation. So that was the level of the injury.
Wonderful.
Perfect. And Dr. Jassir, just to clarify, how do you know how much time from the accident to the trauma bay?
It wasn't clear. It was not reported by the EMS.
Perfect. Okay, I guess you can move on with the presentation. Thank you.
All right. We can push through the slides. All right. So upon 10 minutes of our initial evaluation in the trauma bay, the patient's hemodynamic status decompensated. He became hypotensive, tachycardic, with systolics down to the 60s, and had an altered mental status. We were able to promptly place a subclavian line and an A line on the right radial. We started him on massive transfusion protocol, gave him whole blood, and we were able to take it, and we took him to the OR immediately. On our way to the OR, that being said, we discussed the case with the orthopedic surgeon on call who evaluated the films, and he determined at that time that the pelvis could not be externally fixated due to the extent of the bony injuries. We also discussed the case with the IR team from our hospital for preemptive consideration of embolization in case we weren't able to control the bleed in the operating room. So we moved to the OR. There you go. So we started with a fan steel incision in the operating room. We cut down to the fascia, and immediately we expressed around 400 to 500 cc's of unclotted blood, as well as multiple blood clots. After we were able to pack the preperitoneal space, we moved to the groin, which has actively bleeding, till we explored it and we ligated all the identifiable bleeders. We packed it, and I don't know if you can see here in this previous image in my pointer, this skin flap right here, we brought it all the way back up because the skin was there. It wasn't torn. It was just degloved. And that worked to keep the packing in place, and we immediately replaced the pelvic binder. The patient continued to be hemodynamically unstable, hypotensive, requiring blood products, so we performed an exploratory laparotomy to be sure that there was no intraperitoneal bleeding at the time. There was none. The abdominal organs were intact. There was no disruption of the bladder, so we placed a suprapubic catheter, placed an Apthera, and got out of there. Throughout the OR, he required around 11 units of 1:1:1 pack reds, FFPs, and platelets, and 2 units of cryo. At this point in time, he continued to be hypotensive, but responsive to the blood products. So again, I want to pause and hear what the panelists are thinking at this point in time.
Perfect. Dr. Kasim, can you jump in this one?
So you decided to take the patient to the operating room, which is understandable. And preperitoneal packing is a very good deal. Does your hospital have Reboa?
We do, but due to the extent of the pelvic injuries and the degloving injury, and I discussed it with my attending at that time, we elected not to proceed with Reboa because we deemed it unsafe.
It looked like that the right side of his femoral triangle area looks virginal, and at least I would have considered it. But you have considered it, and you removed it from the armamentarium. That's okay. So I think those of us in where we work in hospital where Reboa is not available, this is the optimum way of dealing with significant pelvic bleed, which is preperitoneal packing, as outlined by the group from Denver. They have done a lot of studies and between doing the preperitoneal packing for pelvic injuries as opposed to not doing it, and they have had a modicum of success in getting the patient out of danger by the preperitoneal packing in the pelvic, and they have special ways of doing it with the, and they make a little round towelette and they pack it on each side, and the video looks very, very impressive. I personally have not done one because I haven't had an opportunity to see one of those. So the problem is sometimes, it doesn't stop all the bleed, and the patient continues to bleed, and then what do? Then you have to resort to help from either IR or use of some type of arterial catheter in the distal aorta so you can float a ribot or balloon to get control of the blood going to the pelvic via the cephalad approach, like i.e. subclavian or radial or whatever it is. Again, like I said, this is a nightmare case, and you have to use all your ingenuity to stop the bleed somehow so that you can keep the patient alive. Otherwise, he's going to die of hemorrhagic shock.
All right, that's great. Dr. Untracht, any additional tips or any comments?
Yeah, it really difficult case because you're between a rock and a hard place. The issue is whether the bleeding is arterial or venous. So now, if it's arterial, then reducing the pelvis would not be as effective as if as it would if it were venous bleeding. And the orthopedic surgeons were not very, they couldn't help you with an external fixator. But what I don't know what they did recommend. The binder would work partially, but it wouldn't work as well. And how effective was the packing? If it's venous, then the pelvic packing should be more effective than if it were arterial bleeding. So when you evacuated the clots, did it look like venous blood or arterial blood? What was your sense of what was going on?
There were clots, but there was also bright red blood.
Yeah, so likely arterial. And then the comments about the Reboa, you're in a very, very difficult situation. If it's arterial, the patient was pretty hemodynamically unstable at that point. And the best way to get control to buy you some time would have been with Reboa, and it might have been worth, I'm not sure what they were worried about for the risk going through an open wound into the vessel. The vessel would the common femoral artery looks like it was almost exposed, but I think it would have been reasonable, in the old days, putting in an intra-aortic balloon, whatever, would involve exposing the vessel. So, if you're in the OR, you're not really having much success, or you have partial success, the patient's still hypotensive, I would have gone ahead and still put in on the right side a Reboa. That would have allowed the patient to get stable and buy you just enough time to get to the cath lab. They can go through the brachial artery if they want, and and then find out where he's bleeding, put a coil in, to stop the bleeding, because that's what and if it's venous bleeding that he has, you need to somehow reduce. I don't know what did the orthopedist recommend doing with the pelvis if they couldn't put an X-fix. What would they do? Would they go ahead and put some plates in just to, through you had the incision to do the packing, so they could have gone into the space of Retzius, access the pubic bones, in a sterile field, and at least on a partial, put a plate in which they could remove later, but you have to reduce the pelvis if it's venous bleeding, or get control of the arterial bleeding temporarily and get definitive control. If you're really in a bind, then you might have to go back in, probably through your laparotomy, put vessel loops around both internal iliac vessels, to temporarily get control. If you really couldn't use the Reboa, you didn't want to do that, you didn't have the Reboa, that's the best way you get control, and then proceed right away to interventional radiology. Let them identify the source of the arterial bleeders, stop those, and then remove the vessel loops. So, but that's what you're dealing with at this point, and a lot of restrictions on your ability to do the principal points of temporarily getting control of the blood loss and improving the patient's hemodynamics. So you're in a tight bind, but I'm sure you dealt with it rather well in this case.
So thankfully, we were able to keep up with the blood loss, and then we were able to move expeditiously the patient to IR. And here's a picture of the angiogram. I'll let it roll so you can see here. Here's a pretty good image. So in the IR suite, there was clear evidence of extravasation from the branches of the anterior and posterior trunks of the left hypogastric as well as the right hypogastric. So our colleagues embolized the left internal iliac and then the anterior branch of the right internal iliac and the right circumflex artery, which they felt were the major bleeders at this point in time. He, after this, stabilized, and we transferred him to the trauma ICU, still intubated, placed him on broad spectrum antibiotics, and kept resuscitating him. So after we were, go ahead. Sorry, I thought someone was going to mention something. After we were able to stabilize the patient, we took him to the scanner and basically scanned him head to toe. And here's a picture of the scan real quick. There were no thoracic injuries. And then the vast majority of his intra-abdominal and pelvic injuries extended at the level of the bony pelvis. You can see the packing there and the suprapubic catheter and the staples from when we reduced the degloving soft tissues. And then here is a 3D reconstruction of the pelvis, which I thought was quite a nice image to depict the extent of his bony injuries. To make it short, the full list of his injuries is on the right side of the screen. He had a degloving genital, perineal, and mons soft tissue injury. He had bilateral iliac wing fractures, a vertical shear fracture of the sacrum, a fracture of the medial wall of the left acetabulum. The pubic rami were diastased and fractured, as you can obviously see in that picture. He had a left lateral tibial plateau rim avulsion fracture, the urethral injury at the level of the prostate, which I mentioned earlier, and a left frontotemporal scalp hematoma. I thought it was pretty impressive that the majority of his injuries were contained at the level of the pelvis, and not anything else, given the mechanism of trauma.
Yeah. Dr. Jassir, can you, Dr. Untracht ask you to point out the extravasation on the right internal iliac vein on the IR. Can you go back a little bit, just make sure we can see everything?
Right. So, let me pointer. So on the left side, you can see here branches, and I believe outside of this picture, we had some branches of the anterior trunk. I don't know if this picture shows them well, or if it were maybe the subsequent angiograms. I don't know that I can see it here on this specific shot. But after they coiled this one, they were able to identify them on the right, and that's why they embolized it.
That's great.
I don't know that they did super selective catheterization, and that's how they were able to identify them. I don't know that I can see them in this picture, though. I'm sorry.
No problem.
All right.
Oh, that's awesome.
I think,
and also, Dr.
one of the things.
Oh, sorry, Dr. Kasim, go ahead.
One of the things that the lesson I'm learning from this case is, if you don't have IR, suppose in some hospital where you're working there and there's no IR, I think the right thing that you would do would be to ligate the hypogastric vessel, like Dr. Untracht mentioned, and you would have got good control that way.
And that is something
that
us in the operating room, but we held off due to the morbidity of it and the fact that we did have the IR team ready.
Great. Yeah, Dr. Epstein is also commenting on the chat. He's considering the femoral line being placed very early in these cases as well, and he's a little bit shocked with ortho not attempting the fixation. But I think that this 3D reconstruction may explain why they can't do this fixation, because the left side is destroyed, right? So I don't think they would have anything to use as support for the fixation. So I guess that's why they opted for not operating this case
Did the
Yeah,
orthopedic surgeons actually show up to see this patient?
they came. Yeah, they came.
They came. Okay, good.
Were they aware of the comminution of the left iliac crest like that? But yeah, I agree that they couldn't. External fixator wouldn't have helped in this case. But I don't know. Did they know at the time that
With the X-ray, they were able to see the fractures on the left, on the iliac crest.
Yeah.
And they felt like they would not be able to externally fixate because they wouldn't have anything to anchor it to.
Yeah.
But they came in. When they came in, we were already in the OR. As we called them, they were reviewing the films when we were rolling back.
A good call on their part?
Yeah.
And Dr. Jassir, what did you do with the laparotomy? Did you close it? Did you use any?
We placed a temporary closure on Apthera.
Perfect. All right. I guess
Yeah,
you can
no.
move on, yeah?
We did not close the laparotomy. All right, so moving on with this care. After the first 24 hours of admission, basically on the 24-hour mark, the patient again became progressively tachycardic and hypotensive. He kept bleeding through his groin dressings from the degloving injury, and his hemoglobin dropped around 3 grams, which was much slower than his initial bleed, but it was still significant enough to be made him hemodynamically unstable. So let's hold off again. And what would you guys do at this point in time? He already got IR. He already got preperitoneal packing. He's hemodynamically unstable and he's bleeding through his genital wound.
Great. Dr. Untracht, any thoughts?
Yeah, so bleeding, bright red arterial blood, venous blood.
It was bright red.
Yeah, and hemodynamically unstable to what degree?
His systolics were down in the 70s, enough to need pressors and more blood, and his hemoglobin was dropping.
Right. So yeah, tough situation. It's options are go back to the OR, go back to interventional radiology to see if they can find either another bleeder that opened up or their initial coil, if that is still if that's holding, and if his condition is deteriorating too quickly, then you need to go back to the OR, get control. If you can, again, go back to the Reboa if he's getting unstable, and you need to have a more precise diagnosis to avoid getting to avoid meddling in a wound that's going to cause more bleeding if you open it up. So if you, and I'm sure you didn't put in the Reboa, but if you had access to it, you didn't do it before, that's an option. Then go to, resuscitate him, go to CT, find out where he's bleeding, or go straight back to interventional radiology. Barring that, you'd need to go back to the OR and at first explore through the wound, see where the blood's coming from, pack it, see if you can stop it, or if he responds to packing, resuscitate him. And if you're not making progress, then, the Reboa, if you've ruled that out, then the ace in the hole is to go back into the abdomen and get control of the internal iliac arteries bilaterally, and then that'll buy you time to let the interventional radiologist look again with a hemodynamically resuscitated patient. So those are the options. I would follow in that order. Reboa, if not Reboa, exploring the wound, packing, trying to get the patient stable. If he won't stabilize, laparotomy, and temporary control of the internal iliac vessel arteries.
Great. Dr. Kasim, any other thoughts?
Well, how about before we do all those wonderful things Dr. Untracht has mentioned, how about just simply looking at the coagulopathy of this patient, because we have already given him a lot of external blood product, and he may be coagulopathic. So I think I would start there first and correct any coagulopathy this patient may have, and then give it as considerable attention to what Dr. Untrak has talked about.
So throughout, if I may chime in, throughout his hospital stay, and we do this routinely at our center, we correct coagulopathy. We use STEG and we also use PT, PTTINR, and fibrinogen, and correct appropriately. And at this point in time in his care, he was not coagulopathic. He was becoming uremic, but not coagulopathic.
Well, uremia can give rise to bleeding as well.
Yeah. All right, so we took him back to the operating room. We started by re-exploring his wound because that was the obvious site of bleeding. And there were some active bleeders, arterial and venous, which we were able to ligate at this point in time. He did continue to require blood products. So we reevaluated the preperitoneal space and the abdominal cavity in that order. There wasn't significant bleeding from either, so the preperitoneal space was repacked, the epithera was replaced. There was notable bowel edema, and he got about 7 units of red, 7 of FFPs, and 1 pack of platelets. At this point in time, the patient was hemostatic. As I mentioned earlier, he did develop an acute kidney injury and was somewhat uremic, and he required dialysis and CRRT. 48 hours after admission, the patient progressively became hypotensive, again, tachycardic. He required significant vasopressor support. And due to his hemodynamic instability, we had to reevaluate his wounds at the bedside to ensure that he wasn't bleeding. And by his wounds, I mean the groin wound, the preperitoneal, and the abdomen. There wasn't significant bleeding from any of these, but the bowel edema was significantly improved. We did take wound cultures at this point in time of the degloving injury, which eventually grew ESBL, E. coli, and rare Klebsiella pneumoniae, which proved to be sensitive to linezolid, so we escalated his antibiotic regimen to that. Throughout the next days in his hospital stay up to day 6, we were able to wean off his pressors. His hemoglobin remained stable. And on hospital day 6, we took him back to closed fascia. And the next day, we were able to extubate him in the ICU. All right. So moving on to the management of the pelvis on hospital day 11, when the patient was finally rock solid stable, orthopedic surgery did end up taking him to the OR for external fixation of the left tibial plateau, where he had his avulsion fraction. They did do some internal fixation with open reduction of his left iliac wing fracture, an anterior pelvic external fixator with a close manipulation of his open book fracture. And I'm pretty sure I have an image here of the hardware they were able to place right there. Throughout the rest of his hospital course, he required multiple perineal wound washouts and debridements to ensure healthy granulation and appropriate healing from his wound. When he reached good vital appearing granulation tissue at the level of his open wound, we had to upscale his wound care with TID dressing changes. We started with some Dakins to ensure antimicrobial coverage, and then we eventually transitioned him down to just normal saline moisture dries. Urology evaluated him throughout the care, and they recommended 8 weeks with a suprapubic catheter and an outpatient follow-up for consideration of urethroplasty. And then he was eventually advanced to a mechanical soft diet. He worked with physical therapy, and we were able to discharge him to a skilled nursing facility on hospital day 32. In a happy note, he recently came back for removal of his external fixators and is doing well. Finally, I think one of the most important things to note from this patient presentation and the management is recognizing and managing hemorrhagic shock, the importance of whole blood and massive transfusion protocols to avoid coagulopathy, and then just stop the bleed, the strategies that we could have taken in place. One of the things that I discussed later on after the whole hospital course of this patient with my attending was the possibility of getting control of the internal iliac vessels in the OR. We were already there. It's something that we could have done there, and we just maybe he thought about it, but I didn't discuss it with him at that point in time. But yeah, the pelvic binder as initial steps, preperitoneal packing or Reboa as an alternative. Laparotomy to rule out intra-abdominal injuries, I think, was crucial in this patient, because if he had something there and we would have missed it because of a negative EFAST, it would have been catastrophic. And then the help of IR embolization. One of the tools that we don't have available in our institution is a hybrid OR, which would have proven to be very helpful in this particular case, I believe. Then another thing that I think is pretty important is recognizing and managing septic shock. At some point in care, this patient's care between hospital day 1 and 2, he started becoming septic after he was hemostatic, and recognizing that and getting the appropriate antibiotic coverage, the appropriate wound care, was also part in this patient's care that I think was crucial. And I think that's it. I think we covered the majority of the cases. I don't know if there are any comments or discussions that.
Yeah, perfect. So there's a question from the chat that is very interesting to discuss. It is coming from Dr. Yoshiro Kobe, and he is asking if you considered doing ostomy for this patient somewhere during the care that he was in the hospital.
We did, and it was a long discussion because let me roll back to the slide where you can see the injury. But as you can see here, it went up basically from the lower part of his abdomen, from the mons, down to the perineum. But we evaluated him in the trauma bay, and we also evaluated him in the OR. I don't know if I mentioned it earlier, and his anal sphincter was intact, and there was no blood in the rectal vault. And more so, the CT scan didn't show any bowel injuries, and when we did the laparotomy, bowels looked fine. So we did consider it, but we didn't think it was appropriate or necessary due to his presentation and no injuries to the intra-abdominal contents.
And were you able to adequately control the fecal output without it, like during
so you mean for the wound? Yeah, he had a fecal management system for a short while, especially when he was intubated, but eventually we were able to, again, move this flap up and pack it. This flap right here, we were able to reduce it basically back up and pack it and start reducing the amount of packing more loosely until we were able to reduce the dead space. And then when this, I don't have a good picture of it, but when this skin, basically the crevice of the degloving was right at the base of the penis and up to his, I guess, left ASIS. And when we were able to reduce, all this dead space was pretty far away from the anus, except for the bottom part.
Yeah, that's great. Dr. Untracht, any final comments?
Yeah, so that last episode of hypotension was just septic shock, and the linazol had cured it. There you go. So it was good, a good ICU care. And do you guys follow him in the ICU, or a different part of your team is in the ICU while you're in the OR? Or?
We follow in the ICU. So our distribution of residents and attendings, we have one attending that's covering for the acute care surgery part of the hospital and the ICU. We have one primary attending doing OR and trauma calls and one backup attending. Our residents are distributed basically the same. We have one mid-level, which is a 2 or a 3 that covers the ICU and the acute care service, which is not an extensive list, but it gets long enough, so it's good work. And then we have basically a 1, a 2, a 4, and a 5 covering the trauma cases to take care of the trauma alerts and the OR.
Yeah. So yeah, beautifully handled. It was a great save. You did a great job. So this poor man, a lot of bad luck, more than his fair share, but he had some good luck when he came into your ER. About that wound, so how far out is he now from the trauma? How is it, more than a couple of months?
Yes, so he got discharged around mid-January to February, March, so 2 months from discharge.
Okay, because that wound, the perineum, it looks like a huge wound, but once the bacterial load gets below what, 10 to the 5 organisms per gram, it closes very quickly, and also a wound vac on that wound after the infection was gone, the pelvic shock resolved. That probably would have been a great solution in that case, and I imagine he's seen the plastic surgeons. Likely, he's going to need some groin flaps to recover the penis and the scrotum, and everything else will just heal in, I imagine. But what does the wound look like now?
I don't have current images of the wound. As I said, for the most upper part of the wound, this was all exposed, but this little sliver of skin, basically we were able to move it up here, and from the base of the penis down, except for the tear on the right side, it was covered. The penis was covered. It was just degloved from the top.
And so all that skin that was degloved, none of it necrosed. You didn't have to excise it.
Some of it did. We had to excise a bit of it, but we weren't able to place a wound vac on him because of the bacterial load initially.
Yes.
So that's why we instated the 3 times a day dressing changes, which helped quite a bit. I haven't seen him in clinic, but I'm assuming that he's probably going to need a graft, especially for the top part.
Yeah, but right, and a lot of that will close in. It's just the body is very good at closing wounds, especially there. And I agree about the lack of the colostomy, because you can manage that, with the diet, a clear liquid diet with full nutrition, or good bowel management. But they very very.
No, some old 11.
Very well
I
handled.
somehow stumbled on, I'm not on Facebook, but
Thank you.
Yeah, that's great. Dr. Kasim, any final comments on this case before we finish up? You're muted, Dr. Kasim.
Dr. Fauzi, is this a dedicated trauma center you're working at?
It is a dedicated trauma center. We also cover for acute care surgeries but the vast majority of our census, which ranges from a 50 to an 80 patient list, is all trauma. It's a level 1 trauma.
How many beds do you have?
I don't know the exact number of beds. Maybe Dr. Jabour or Dr. Lautenberg know the exact number of beds in the hospital.
I must take my hat off to you and your team. You did a fantastic job. The only thing that I would have done a little different, I would have done a endoscopic evaluation of the anal sphincter as well as the lower colon. Superfluous, but it is in my armamentarium to do that when I see something like this. But you covered everything, and I think I take my hat off to you. Very nicely managed. This patient in some other centers, he would have been dead. Sorry. I think you did a fabulous job. I admire your dexterity and your dedication in saving a life. Thank you. And I learned a lot from your case. Thank you.
Very much. It's very flattering. It's thanks to my bosses. I've learned everything from them.
Yeah.
Yeah, that was a great case. I see that Dr. Martos is on the meeting as well. Dr. Martos, do you wanna chime in and make any comments?
Yes, I'd like to say thank you very much for this presentation from FCOT. Another great case, and say hi to all my friends, and a special hi to Dr. Lautenberg. Okay, that's here. So I saw he's here somewhere. He was watching. Larry, thank you very much for being here as well. And Carlos, good moderation. All my friends, don't try. You can see my Dr. Jassir, everybody. And Fauzi, excellent case. Keep going, okay? Thank you. Looking forward for the next one.
Awesome.
Take care.
Dr. Jassir, thank you very much for presenting this case. Very good job, and also I always like to highlight these cases that are very well documented. So it makes this meeting very interesting, and way more interesting with the images and all the discussions that we can make on top of the images as well. So that's very interesting. So in the chat, as a final comment here, there's so Dr. Lautenberg, he's saying that St. Mary's Medical Center is a level 1 trauma center in West Palm Beach. Kevin, can you unmute Dr. Lawrence, please? Yeah, so he can make some comments.
Yeah, just did.
Hi.
Great.
Hi,
Dr.
everybody.
Lautenberg, yeah.
Great to be back on this, and it's great to have my partners in Fauzi bring you this case. St. Mary's is one of the 2 level 1 trauma centers here in Palm Beach County. We are, a full service level 1 trauma center, and I think this case points out the fantastic ability of my partners to be able to manage these cases. We're not a university trauma center, although it is the trauma center that we use for our residency program here at Florida Atlantic University. But you can see here how this case has developed over the years, and I think we owe a great debt of gratitude to Dr. Robert Borrego, who's been the trauma medical director there for 35 years, since the inception of this trauma center. We were able to quickly mobilize IR. We called them as we left the trauma bay off to the operating room, and they were there ready to go when we were ready to go. I kind of agree with everybody. I probably would have placed the Reboa right through the femoral artery. I've done that several times myself with no problem. Although getting him quickly to the OR and evacuating the preperitoneal space and packing it, I think was a great temporizing maneuver prior to IR. And I think it was great that IR was there. And as soon as we finished the preperitoneal packing and the quick laparotomy and put the Apthera on, we took them right from the OR to the IR suite, and they attacked, that bleeding. But no, this was really a great case. And, certainly Dr. Adam Mann, who was the trauma attending with Fauzi, really worked hard to get this patient through. Yeah, we probably might have considered diverting him, but I'll tell you, in the last few massive pelvic fractures that we've done, diversion has always been a problem with these open abdomens and placing the stoma and things like that. So if you could avoid it, it would be great. But I got to tell you, this worked out really well. We don't have urology in the house. We put in our own suprapubics. We do our own urethrograms. As far as ortho goes, there was no question when ortho looked at that plain film, they said, there's no way we can get a fixer on this with the bones like this. And I think when they did the 3D recon, we were pretty convinced they knew what they were talking about. And it was a pretty difficult reconstruction, even to get that iliac crest back together so they could land the fixer and get it across. But it worked out.
Yeah.
So thanks for having us.
Thanks a lot for being able to present this case. Dr. Jassir and all the team that was involved in this case, congratulations. Beautiful case, very well documented. And so I wanted to thank you all for being here, all the participants and all the panelists as well. It was a very interesting case, a very good discussion, and I hope I can see you all next Monday. We're going to have the joint the other meeting from the PTS, and soon enough we're going to have the joint meeting with the PDS and WAST as well to have another great discussion. So everyone, thank you very much for being here. I hope to see you all next Monday. Bye-bye.
Bye-bye.